I would like to thank the organisers very much for asking me to speak here today on working in ICU during a pandemic, difficulties, challenges and changes. So what I hope to show you in the next 15 minutes or so is that the countless small deeds of unknown people working together with one aim in mind is what matters. And the aim in this case was a good outcome for all of our patients, be that survival or a good death, and to maintain safety for patients, the public, and for each other. So our challenges were very significant here in Tallaght Hospital, starting from an already resource-restricted system with little isolation facility. We had 2 isolation rooms, and we run at 100% capacity all the time. The challenge was to accommodate a combination of patients and to keep them isolated from each other. The patient types that I'm referring to are patients who had COVID confirmed, query COVID, who didn't have COVID, and there was also the surgical emergencies that had to go on as per usual. The difficulties we encountered could be summarised under capacity, staffing and equipment. Now, capacity refers to surge capacity planning and the ability to increase the bed stock in ICU quickly. Now, about once every 6 years, I guess, since 1997, we have been threatened with a pandemic, but we've never had to activate our plan until now, now that we had SARS-CoV. So the problem was trying to work out how many patients we were going to get. Was it going to be 5% of a large number or 5% of a small number? So the rest of my talk will cover the items mentioned on the slide here. So we had a graded escalation plan, and the whole point of an escalation plan is that you increase the number up to 1 to 4 as the number of patients increases. Our problem here really was that because we had nowhere else to go except into the operating theatres, the post-anaesthetic care unit and the recovery unit, that we had to escalate at an earlier phase than we would have liked to have. Because the whole idea with an escalation plan is not to interfere with the services and the rest of the hospital until you really have to. That is moving on to setting up then. That's a lighter moment where we were trying out some PPEs for ourselves. A prize for whoever can guess who that is. Moving on to the setup of the expanded capacity, that was undertaken by the ICU team under the leadership of Patricia Morrison, Lisa Dunn and Arabella Fahy, our consultant lead, and the OR staff led by Coach Tobin and the PACU staff led by Maria Messett. So weeks of intense preparation of the physical facility had to happen. Everybody chipped in. The pharmacists and nutritionists developed multiple pop-up pharmacies in all the different areas. Intensive training and upskilling of staff had to happen, and there was a lot of new equipment sort of dropped in from the HSE that people had to be made familiar with. And to us, the most important thing of all was training all the staff in the use of PPE. I put that up there. The photograph on my left here shows you the type of equipment that's required to run an ICU bed. On the other side, you can see one of our operating rooms. Converting an operating room into a functional ICU is quite a challenge. You can see there that we were trying to fit 2 beds into 1 operating room. In this picture, you can see the people who made all that happen. Stephen and Paul are theatre and ICU engineers. So they performed the gargantuan task of installation, testing, training, and maintenance of all of this equipment. So the physical layout, a lot of detailed planning had to go into that. The overriding principle when planning physical layout is that we wanted to prevent the spread of the virus to non-COVID areas and to the rest of the hospital and so on. So detailed mapping of patients' pathway through the hospital to get to the ICU and within the theatres, and the flow of patients and, or rather the direction of flow of patients and staff through the infected and non-infected areas had to be mapped out very carefully also. Donning and doffing stations had to be positioned in the correct places. And finally, we had to construct a bed map showing the location of all the patients in the extended ICU area, because we now had patients in the ICU, in the PACU, in the recovery, and in the operating theatres. I don't expect you to read that slide, but it was really just to show you that this is the floor plan, the detail that we had to go into. This is the floor plan of the ICU, 6-bedded area. And at the bottom of it, there's like a secret corridor, if you like, that leads down to the back of the operating theatres here. And the operating theatres, we took over this 6, there's 12 altogether, 6 here and 6 here. So we took over this 6, we took over the post-anaesthetic care unit, and we took over the recovery unit. The operations had to go on as usual for emergency cases, so they still had this half. So you can see why the flow was so important. So as the logistics of running the whole operation in the planning phase and in the day-to-day phase was complex, we needed an operations room. So the operations room was manned every day by a consultant coordinator from 7 in the morning to 8 in the evening, Monday to Sunday. The bed map that I talked about was displayed and updated in real time. And our overriding thought all the time was, where are we going to put the next patient? There had to be an executive meeting every day, and all kinds of issues were discussed at it and problems. And the ops room also contained the multiple rosters and shifts and so on that were required. This is a photo of a bit of the inside of the operations room. You can see the screen where the bed map was displayed, and obviously there we were using all kinds of technology. This is a map, the bed map, as I talked about. You can see on the left here are all the areas that there were patients located. And so I think it's important to say at this point that we started from 100% capacity. And at the peak COVID time, we went up to about 175% capacity. So at that point, we were really stretched. It was very hard. I think at that stage we could say that we understood what Wellington meant when he commented after the Battle of Waterloo. It was a damned close run there. It was a damned close run thing there, because if the numbers hadn't settled, then we would have been in big trouble. So everybody had to adopt a new daily routine, whether they liked it or not. That consisted of the day being split into two 12-hour shifts. There were 2 consultants covering each shift along with the trainees. All the consultants, the ICU consultants, pain and anaesthesia, took part. The way the day operated was we had a handover, and then there was a bedside round at the beginning of every shift. We had to function in teams because the COVID team couldn't look after the non-COVID patients and so on. So that meant that we had 4 teams in total. So after the round, or after the handover, we started the round. And before going into the COVID area, everyone, all staff had to don. And we took the donning of PPE extremely seriously. In fact, we had a donning supervisor, and that was our healthcare assistants, who took this on as a new task for them, and they took it on with great pride, and they did it with good nature and a laugh and a joke, so that the people going into the COVID area were relaxed going in, and more importantly, they felt safe. This is the entry point to the COVID area. And as you can see, people were trying to keep things lighthearted where possible. You can see there staff donned and ready to go in on the left, and on the right you can see Dr. Fahy wearing the additional PPE required for aerosol generating procedures. It was, by the way, pure coincidence that she ended up looking like a nun in that. So I'm just going to move on to some of the challenges there of wearing PPE. PPE is very hot to wear for any length of time, very hard to tolerate. People got dehydrated. The longest you could probably wear it would be about 3 hours, which was hard on the nurses. The goggles were sore on your face, especially if you had glasses. It was literally a pain in the face. You might say, why didn't you wear a visor? Well, after you have a visor on for a while, it starts fogging up, and if you have glasses as well, so you've got fogged glasses, a fogged visor, and then you've got drips running down the inside of the visor from perspiration. So as you can imagine then, that performing procedures in all that gear is pretty difficult. Other things that came up were that it was hard to identify other people, so people had to wear name badges. And it was concerningly, it was very hard to hear with full PPE on. So if an emergency was happening where you had to give and receive clear instructions, it could be a bit of a problem. Communication challenges then, well, it wasn't quite as primitive as the picture portrays there, but we had to get messages from the inside to the outside and the outside to the inside. So there was a runner stationed outside to go and get things. You couldn't store everything you needed in the unit. But this is where the technology really came into its own, because we used everything, walkie-talkies. Paul Ridgway got us an Alexa, computers, iPads, you name it, we had it. And that shows you some of them. I'm going to move on now to what effects some of this had on patients. So we had our first outpatients clinic for follow-up this week, and you can imagine that a patient who had been put in an induced coma for up to a month woke up, and this was all very frightening for them. And I can tell you that some of this was woven into the fabric of their nightmares. They found it hard to identify staff, again, same as us, difficult to hear. No familiar faces either, and the relatives weren't allowed in, and a lot of the relatives in truth didn't want to come in either. Human touch is not the same through 2 layers of plastic gloves. However, the nurses, or we realise this is a problem for patients in general, so we try to keep patient diaries so they can read them later, and that seems to minimise the amount of post-traumatic stress disorder that they suffer. What effect did it have on relatives? Well, they couldn't visit their loved ones. Their whole day revolved around a phone call. They were frightened if they didn't hear the phone ringing. They were terrified if they did hear it. Receiving bad news by phone is not a great thing. As you know, most of our, or a lot of our communication is non-verbal. And the other really difficult thing was patients dying without their loved ones being able to be there. However, the nurses did what they could to alleviate this, and I just want to take a moment to tell you what they did, because I think they were wonderful. So the nurses decided that if a patient was dying, that it was very important that they were never alone. So a person or a nurse stayed with them for the entire time. They, if possible, set up a FaceTime with the family using the iPad, situated so that the family could see their loved one's face. The family could talk to their loved one and say their goodbyes, and either a prayer was said or music played, depending on the preference of the family. The nurse would interject with updates on the patient's condition and to tell them that their loved one had passed. FaceTime continued if the family members wished for some time after the patient had passed, and then the nurses offered them either a lock of hair or a handprint if they wished. So moving on to the effect on staff. So the staff were afraid to go home because they didn't want to affect their families. So some staff stayed remote from their families for prolonged periods. This led to isolation and loneliness. However, a great support network came into being between the different groups, and our NCHDs there, for example, whenever they had to break up at the end of June to go to their next location. Some of them were quite devastated. You know, particularly strong bonds seem to develop more so than usual. Of course, psychology service were on hand to help us. So I'm going to mention a little bit about the support that we got from colleagues. Proning treatment was one of the only treatment that works in these patients. That means that patients were placed face down for 18 hours at a time. And that was a really big deal, putting patients like this, who have all these tubes and pipes and so on, turning them in a face down position safely. If their breathing pipe fell out, they would have died before we could have got it back in again. And there were many patients that we had to do it on at the same time, 4 or 5. So we needed a proning team. So that's our proning team. They all came together. They were from all kinds of walks of life, if you like, in the hospital, from Professor Ridgway, you name it. They were all trained up really quickly. They came twice a day reliably at 10 in the morning to turn patients supine and 4 in the evening again to turn them prone. One of the big advantages of that was, apart from taking the stress off the already overburdened staff, was that in the COVID unit, the amount of through traffic was minimized. There was very few visitors like there would have been in the past. So it was quite isolating for the nursing staff. So they really looked forward to the proning team arriving, and they were very upbeat and jolly and kind of, again, raised the tone. This just shows you a team performing proning. And then moving on to other helpful colleagues, our laboratory colleagues. They were essential to us as well. What I don't know if you realize or not, that to do effective REMS, we need our cumulative blood reports. And these provide us with a window, really, if you like, into the inside of the patient to tell us what's going on, because a lot of the time the outside of the patient doesn't give you that much information. So the lab staff, without any prompting, compiled a COVID panel for us and continued to evolve it as time went by. And in addition to that, they put up a really good results section for us every day for every patient. The results are very important to us because they reflect the trajectory of the patient in the ICU. And in fact, what we found was that they often warned us ahead of a clinical deterioration that trouble was about to happen, so we could intervene earlier. The local community helped as well, and they supported us all the time with lots of goodies and foods and very nice messages. So I'm going to finish up now by saying I hope I have convinced you that the countless small deeds of unknown people working together with one aim in mind is what matters. So how did we get on in our aims? Well, altogether, all of us achieved a very high survival rate in the sickest patients, greater than 80%, which was a lot better than a lot of other countries experienced. Excuse me. We also managed to protect our staff in that we haven't found any that actually contacted COVID through their work in the intensive care unit. I'm going to finish up with this picture showing you some of our staff, and also to say that our biggest challenge is yet to come, and that is, will we be able to do it all again? Thank you for your attention.